episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor. Welcome everybody to another episode of our show, bringing you again another fascinating individual who is helping to create a better tomorrow for millions of people around the world. We have the honor today of being joined by Dr. David Cooper, who is a pioneering heart transplant surgeon and researcher in the field of xenotransplantation, which is broadly defined as any procedure that involves the transplantation, implementation, or infusion into a human recipient of cells, tissues, or organs from a non-human animal source. Dr. Cooper studied medicine in the UK at Guy's Hospital Medical School, now part of King's College London, trained in both general and cardiothoracic surgery in Cambridge and London. Between 1972 and 1980, he was a fellow and director of studies in medical sciences at Magdalene College, Cambridge. In 1980, he took up an appointment in cardiac surgery at the University of Cape Town, where he worked with Professor Christiaan Barnard and responsibility for patients undergoing heart transplantation. In 1987, he relocated to Oklahoma Transplantation Institute here in the US, where he continued to work in both clinical and research fields. And after 17 years as a surgeon and scientist, he decided to concentrate on research, initially at Massachusetts General Hospital, Harvard Medical School, subsequently University of Pittsburgh, and then University of Alabama in Birmingham, where his major interest was in developing cross-species transplantation, ultimately with the aim of using pigs as sources of organ cells and corneas for transplantation humans. Professor Dr. Cooper has published over 1,000 medical and scientific papers and chapters, has authored or edited 18 books, and given over 300 presentations worldwide on many of these topics. And we're very excited to have him with us today. Dr. Cooper, thank you so much for taking the time out of your schedule to come talk to us for a little while.
Thank you very much for that, for a very kind introduction. You failed to mention I'm actually back at MGH and Harvard Medical School now, since last September.
Absolutely. Apologize for that, but yes, thank you. Thank you for completing the bio. I appreciate that. Dr. Cooper, I would love to just start off, obviously, as a transplant surgeon, this tremendous gap between patients and organs was always front and center throughout your work over the years. Tell us a little bit about when the idea, the interest in some of these alternatives like xenotransplantation first came across your radar when you first got interested in, hey, there has got to be an alternative way to do this.
Well, I thought about it several times, as many surgeons have done, because of this problem of having patients waiting for months or years for a transplant. But when I was with Professor Barnard in Cape Town in about 1980, I realized that our biggest problem was not getting the patient through the transplant, which was difficult in those days, but the problem was getting a donor organ, because many patients died while they were waiting for a donor organ, and they still do, unfortunately. And so I then, particularly as baboons and monkeys were very inexpensive and readily available in South Africa, began to look at the possibility of cross-species transplantation, or as you say, xenotransplantation. Baboons, for example, were shot if they were on the fields of the farmers, and instead of shooting them, they began to capture them and bring them into the main facility, and we were able to purchase them for $25 each at the time. They now cost me between $8,000 and $10,000 each here. So you can see how easy it was to use them there. And so I began first by transplanting, say, monkey hearts into baboons, to two different species of old world monkey, but soon realized that that wasn't going to solve the problem. There were not enough. For example, if you wanted to use a baboon for a human transplant, for baboon heart, say, to transplant to a human, there were never going to be enough baboons available to solve the problems that we face. Baboons take about 9 years to grow to full size. They breed in ones or twos. And it became obvious that the pig would be a better animal source of organs. They breed in 10s or 12s. They are adult size and can become pregnant at 6 months. And so logistically, they were a much better bet. And so I began to look at pig to baboon transplants, using the baboon as a surrogate for the human. And found, to my not surprise, because I'd read a little bit about it in the literature, but nobody had done the pig to baboon model before, that these organs were rejected sometimes within 5 minutes. It was quite dramatic how quickly they were rejected. And that is because we and baboons have antibodies against pigs already there in the blood. And so as soon as they bind to the pig organ, they activate a series of events that causes immediate rejection. It's the same sort of thing. It can happen if you have an ABO incompatible transplant. Right. And this was quite dramatic. So I realized we were up against a big problem. Even if you gave the best immunosuppressive therapy that was available at the time, didn't make any difference to the outcome. So we began to do some studies where we removed the antibody from the blood. We passed the blood through either a separate pig organ so that all the antibody bound to that organ. And then when we put the real organ in, there was no antibody to bind. Or we did plasmapheresis, where you can remove antibody, all of the antibodies from the blood. And this was partially successful, but within a few days, the antibody came back again, and the organ was rejected, maybe a few days later. One important point is, why do we have antibodies in our blood against pigs? Even the people who've never eaten any pork, never been in touch with pigs, they have antibodies. And the reason is that in infancy, we don't have any antibodies against pigs, but once our gut gets colonized by various bacteria and viruses that express on their surface the same molecules as pig organs do, we develop antibodies as a sort of defense mechanism. So everybody during the first year of life develops antibodies against these pigs. So from the mid-1980s, 1985, I think we started doing this. That became my major research interest, and eventually my major career interest. And it's taken much longer to solve the problems than I thought. The big steps that have, the big milestones are obviously our ability to genetically engineer the pig, because we can knock out from the pig the genes for these molecules on the surface of the pig cell against which we have antibodies. So we now have pigs where there are no targets for antibodies in many patients, not everybody, but many patients. And then we can also add to the pig genes for human protective proteins when we activate our own immune system, we don't kill our own cells, but we do kill the pig cells. But if we put into the pig our own protective regulatory genes, then the pig has an added protection from it. So we now have pigs with, as you know, perhaps 10 or more genetic manipulations, all geared to protect the pig kidney or the pig heart from the human immune response. And so that's brought us to the level we're at now. The other approach, of course, is we needed better immunosuppressive drug therapy, because even when you put that pig organ in, if you don't give some immunosuppression, you can make new antibodies against the pig to other targets that you don't have already. And the existing immunosuppressive therapy that we use in human organ transplants is not very effective at preventing that in pig organ transplants. And so we've got a new form of immunosuppressive therapy, which we actually were the first to introduce into xenotransplantation back in the year 2000. But it hasn't progressed as much as we would have liked, because there were complications with this drug, which have been now sorted out. And we're getting much better results now than we did a few years back. So that's how we progressed. That's how I got an interest. Seeing patients in the intensive care unit waiting for a heart transplant for weeks or months on end, and eventually dying without a transplant, I realized that this is the problem we need to resolve. And from the point of view of kidney transplants, patients can wait up to 10 years for a donor organ. And if you look at the data, within 5 years of their being on the list, the waiting list, about 45% of the patients have been taken off the list, either because they died or because they became too frail or fragile, or had some other comorbidity that made them no longer a good candidate for a transplant. So people, I don't think patients quite realize this. It's not stressed to them, obviously, because it's depressing.
Sure.
But if you're put on the list for a kidney transplant, within 5 years, you've got about a 50% chance of no longer being a suitable candidate, either because you died or because you've developed other problems. And that's what makes me think that many of those patients, if that's explained to them, would be very prepared to take a risk with a big kidney transplant, because that could support them for some years, perhaps. We don't know, of course, but it might do. In which case, they're not on dialysis at the time. And dialysis is not popular. It takes 3 days a week of their life. You never feel as well when you're on dialysis as you do when you've got a functioning kidney. And so many of those patients would think, I'll have a pig transplant, even if it takes me off dialysis for a year. I'm still on the waiting list for a human organ, and that's 1 year where my quality of life will be better.
Absolutely. Yeah, it's also interesting, thinking about the history. I guess a lot of people also are unaware of, in the sense that pigs have given us heart valves for decades now, and proteins and other therapeutics, going back to the original insulins, certain clotting factors, low molecular weight heparin products from pigs. The pig has really been an amazing reservoir for us in terms of health. As you were thinking about the pig, Jen, I mean, obviously you've been very focused, and obviously with the recent news on the heart and the work that's going on there, you mentioned the kidney. In general, are pigs perfect for every organ for humans, or are there, as you've been studying this along the way, obviously, the issues with the non-human primates you outlined, were there other animals along the way that you said, well, hey, this might not be great for a heart or a kidney, but they have great livers, or whatever it may be, we might not hear about as much in the press because the pig has basically taken over the scene in recent days?
Not really. We haven't really considered many other animals as organ sources, partly because of the differences. For example, sheep and cattle tend to live outside, which means you can't protect them from insects, and therefore they may get an infection. They breed in much smaller numbers, and so the pigs, from a logistic point of view, seem to be the ideal candidate as an organ source. And as you pointed out, we've used pigs for many different purposes. The original insulin was used for pigs to treat patients. We slaughter over 100 million pigs a year for food in this country. Yeah. And I'm told that in China, they kill 500 million as a source of heparin, as you mentioned. So we're very used to using pigs for whatever we need in life.
Dr. Cooper, I have in my library here, I have your book, Xeno, from I think 2002 or so. And you co-wrote this book at the time with Dr. Robert Lanza of nuclear transfer cloning fame. You mentioned early on, some of the genetic manipulation that you're looking to obviously get rid of some of those histocompatibility issues, but also engineer in some of the factors that may be more protective. What are some of the other things that sort of in the ideal CRISPR genetic engineering world that we sit in 2022, possibilities that excite you in terms of genetic alterations that may enhance engraftment or growth or other beneficial components of the transplant process that we haven't gotten to yet?
Well, the first thing I point out, which is obvious but we don't often think about it, is this is the first time in the 70 years that we've been doing organ transplants that we can actually modify the donor as opposed to just suppressing the recipient. Yeah. And the more you can do to the donor, the less you have to do to the recipient. And I firmly believe that in a few years' time, we'll be doing everything to the donor, and the recipient will need either no immunosuppressive therapy or very little immunosuppressive therapy. We've already done this in pigs, put an immunosuppressive agent into the pig. In fact, when we tried this, it was too successful because the pig was producing so much immunosuppressive therapy that he immunosuppressed himself and began to get infections and so on. So we need to revise that approach. But I'm sure if we can just put that immunosuppressive agent into the organ that we're going to transplant, so the organ is producing its own local immunosuppressive therapy, this may resolve the problem. But there are other points too. For example, if we found that the pig liver, which produces hundreds of different proteins for us that we need to keep alive, if we find that the pig liver doesn't produce something that's important, we can genetically manipulate the pig liver. Instead of producing the pig protein, it can produce the human protein. So we can make these organs functionally improved or different if we need to. And that's another very important point. So we should eventually be able to produce organs that will fulfill any purpose we want, as well as being resistant to rejection. We are talking mainly about organ transplantation, but there are a lot of other fields where the pig xenotransplantation will be, I think, become very, very important. It'll revolutionize medicine. For example, there's a group of my colleagues in Europe who some years ago treated monkeys with a Parkinson's-like condition by putting pig brain cells that produce this dopamine, which is what you lack in Parkinson's. They put those into the brains of these monkeys and saw dramatic improvement in the monkeys as regard to the problems with Parkinson's disease. Corneal transplants, of course, is another obvious situation where we could use the pig cornea. I'm told that in China, there are 4 million people who would benefit from a corneal transplant. And we have been doing some work over a number of years on pig red blood cell transfusions. Many, as you know, most people who donate blood, you have to test the blood for all sorts of infectious microorganisms, make sure you're not transferring rabies or something with the blood. But pigs will be housed under these clean conditions. They'll be monitored carefully, and we will know that they don't transfer any infectious diseases or infectious microorganisms. And so I firmly believe that eventually all of our blood transfusions will probably come from pigs. We've mentioned diabetes because we said that pig insulin was used for many, many years before we had human recombinant insulin. So we know pig insulin works well in patients with diabetes. And if you transplant the pig islets from the pancreas that actually produce the insulin, the patient would be self-sufficient, wouldn't need any insulin injections, because the pig islets will respond by producing insulin when it's needed, and they'll stop producing when it's not needed. And so there's a whole host of conditions that I think will eventually be using pigs as the source of therapy for these conditions.
And as you just brought in one other thing to mind, a couple of years ago, I was talking to some of the folks, and maybe people listening to the show might not be aware, but in recent years here, in the U.S., the FDA has approved both leeches and maggots for as sort of living therapy for debridement of non-healing skin wounds. And part of it is sort of this chewing process they do, but other parts of the saliva they secrete with all sorts of interesting growth factors and clotting factors, what have you. Any interesting stories along the way about things that some of these organs may secrete from other species that we might, you would say, we might not be great at as humans, but wow, they make a lot of it, and that not imparts any superpower or anything, but actually is better in certain ways than the human organ.
Well, I can't think of any obvious examples. The most important thing from us, of course, is the pig organ going to be able to function just as a human organ would? And with the heart, we know from this recent clinical experiment where patient in the University of Maryland, my colleagues there, transplanted the heart. The heart is doing very well. Now, the heart is a fairly simple organ. It contracts and beats, whereas the kidney and the liver are much more complex in their functions, much wider range of function. But all the evidence is that certainly with the kidney, we've recently done some work on the function of the pig kidney after transplantation, and it looks as if it will do all the things that we expect it to do that a human kidney would do. And there are other groups, colleagues of mine in Minneapolis, for example, who've now got some monkeys who've been supported by a single pig kidney for up to 3 years, and they're completely healthy. And so that confirms that now those kidneys were not the kidneys we would put into a patient, but they're good kidneys for the monkey. But it confirms that if you've got the right pig and the right kidney, that it will keep you alive and well, and there'll be no limitation on the function of the kidney. Now, as I mentioned, the liver is more complicated, and we don't have long-term survival of livers as yet because the immune problem is also more complicated. As I mentioned, that if we find that the liver is not producing something that is essential to the human, we can genetically engineer the pig to produce that from the liver. So I think, you know, all the data suggests to me that this is going to be very successful and going to open all sorts of possibilities to us that we didn't think about before. I mean, the other area, of course, is skin grafting, which is actually a difficult organ, if you call it an organ, to graft. Skin grafts do less well than some of the organ transplants for various reasons. But there has been work in skin grafts. We've recently done some ourselves, suggesting that at least the pig skin will do as well as a graft as a human skin graft. It may not be there permanently, but it will be important in patients with burns, for example, to cover that area to prevent fluid loss and infection and so on for a number of days or 2 or 3 or 4 weeks. It's just as effective as putting in human skin. The other thing about that is that it's important, and this is actually very important, that if you get sensitized to a pig organ or pig skin, that is, you begin to make these new antibodies against it. If you put another pig skin graft on, then that will be rejected more quickly because you've already got these antibodies. But it has no detrimental effect on a subsequent human skin graft or a subsequent human organ graft. So you can be sensitized and reject the pig organ, but you're still eligible and perfectly able to have a human organ transplant, which is very important. I'll give you a really good example of this that my colleague David Cleveland at UAB and I were very keen on, and still are very keen on. Infants born, babies born with very complex congenital heart disease, where they're probably going to die within a few days unless something's done to them. The best treatment is to give them a heart transplant. In fact, if you can do that in the first week of life, you get better results than with any other organ at any other age group. Those patients may live 25 years, 60%, the graft is still functioning 25 years later, which is extremely good. And we think this is partly because the infant's immune system is rather immature. And so it's easier to manipulate and it's easier to accept that graft. But the problem is it's almost very difficult to get a heart, for example, for a baby at that size. It takes on average about 4 months to get an organ for a baby. And so that baby is either going to die or have some palliative surgery that keeps the baby alive, but the long-term outlook for the baby is not good. And so we firmly believe that if you put a pig heart in the baby and use it as a bridge until the baby gets offered a human heart, our evidence at the minute is that the baby's heart, the pig heart, will probably keep you going for several months. And when you get a human heart, you then replace the pig heart with the human donor heart. This means that the baby is not committed to have a pig heart for the rest of its life, but it will save its life, and it will give us a lot of experience in how long will these pig organs survive in humans. So I think that's something that I think it's actually more justified to do that in a baby than actually to do it in an adult, because in adults you do have assist devices, ventricular assist devices, mechanical devices that can support the patient for many months, even years these days, until you get a human donor heart. In babies, there are no devices that are really efficient in tiny babies. They're just not built that way. And if you try to support the baby with an assist device, there's about a 25% survival at the end of the year. It's a very high mortality, unfortunately. Whereas I think a pig heart would solve the problem.
It's quite interesting because I just a couple episodes ago I talked to researchers over here. I'm in Philadelphia, and Drexel University has this pediatric engineering program. And this is one of the issues they mentioned. We often with some of these devices, we don't think about the fact, okay, this is not just this child, whatever, the 12 years, they're not just a little person, they're growing, and to have something that grows with them along the way, or things in this case, if you can have pigs of different ages and so forth, even if one doesn't take you all the way, and there's still that time required for the human one, it seems like you can breed different ages of pigs as well to fit not just the babies, but so the whole pediatric niche. So I think that's another very interesting possibility here. I don't know.
Let me comment on that. You're absolutely right. You can get a pig as small as a couple of kilograms, and you can get a pig as much as 200 or 300 kilograms. Yeah. So we can get a size organ for any particular size patient. One thing I point out, though, that it was noted by a group in the United Kingdom back in the year 2000, and we confirmed this more recently, that when you put a pig organ into a non-human primate, for the first few months, it grows as if it's still in the pig. The pig is growing very rapidly. For example, if you put a pig organ from a pig that's, say, 2 months old, by 6 months, it will have increased in size many times. Whereas the baboon or the monkey, who's the recipient, will hardly have grown at all during that time, hardly put on any weight. And so the pig organ can grow much quicker than the rest of the baboon is growing. After a few months, it seems to level out a bit, and probably it's because it's no longer dependent on pig growth hormone, more dependent on baboon growth hormone at that point. And this has caused some problems. It doesn't cause much of a problem with the kidney because you've got a lot of space in the abdomen for the kidney to grow, but it does cause problems with the heart in the more restricted confines of the chest. And then the heart can get compressed. And this has been a problem. A group in Munich in Germany have shown that this is definitely a problem. And so you can manipulate the pig by knocking out growth hormone receptors so the pig doesn't grow so quickly. And after the transplant, the organ doesn't grow so quickly. Alternatively, as one of the companies is doing here in Boston, you can use miniature swine as your source animal. They only grow to about 200 pounds, I think it is, or 200 kilograms maximum size, and so they grow much more slowly, and therefore this growth problem is probably not going to be so important.
Dr. Cooper, you mentioned earlier about some of the infectious issues that you seek to avoid, especially in the stem cell related area. Obviously, the term zoonosis has become part of all of our lexicon in the last couple of years with the pandemic. Talk about just the issue of porcine viruses. Obviously, I can't think off the top of my head of any major issues that have happened related to pigs and humans crossover in recent years. Talk about some of the issues that you have to sort of work through as you deal with this part of the issue, and then also solutions, whether the genetic engineering or otherwise, to help balance this.
The pigs will be housed under very clean conditions, and they will be tested at intervals, and so it's very likely that the pigs will be carrying no significant microorganisms that could cause problems in humans. My colleague here at MJ Fishman, who's the world authority on infections after transplantation, and particularly after pig organ transplantation, he believes that the patients will be susceptible to the same infections that patients with human organ transplants are. So that because they're immunosuppressed, they will pick up things that perhaps we wouldn't pick up otherwise. But he says that the infectious disease people these days know largely how to treat those conditions or to prevent them. As I mentioned before, I think eventually we won't the patients won't be susceptible to that because we'll be doing everything to the pig rather than to the patient, these immunosuppressive therapy and so on. But for the time being, yes, they will be susceptible to the same infections that the patients with human organ transplants are. The one exception is that in our cells, we have what we call human endogenous retroviruses.
Sure.
These are little bits of virus, either full virus or particles of virus, in every cell in our body. And it's due to absorption of these virus particles over hundreds of thousands of years.
Mm-hmm. Mm-hmm.
They don't seem to do us any harm. And pigs have pig endogenous retroviruses in their cells, which don't seem to do them any harm. But there was a question raised of when you put the pig organ in, will the pig retroviruses do the human harm? There is no evidence that from all the experiments that have been done over the last 20 or so years that they will be detrimental, but the non-human primates are not a great model for that. And so we're not 100% certain whether these endogenous retroviruses will be problematic in the human. We think they won't be, but nobody knows for sure. Now, one encouraging point was that when this heart transplant was carried out by my colleagues in Maryland 3 weeks ago, the FDA approved the use of pigs, knowing that they had some retroviruses in the cells. So it means the FDA did not think this was a high risk. Now, there are techniques, a company here in Boston, eGenesis, whom I'm consulted to, they have developed a technique to knock out all these viruses, which is quite a major undertaking from a genetic engineering point of view. So they have pigs now that do not have these retro, or at least they can't be activated. And there are other approaches to do this as well. Whether that's essential, probably not, but it's probably an advantage because that means you've eradicated that problem. And so if occasionally they do cause problems, you're not going to be faced with it. So there are all sorts of things we can do with this these genetic engineering techniques to make the whole thing more efficient and safer.
Yeah, I think that's an extremely important point in 2022 that that everything is now converging in the sense of the ability to create these animals in large scale, the ability to do the genetic engineering that has been needed. It's an exciting time. As far as next steps, Dr. Cooper, you know, you're as mentioned, you're back at Harvard now. You had major excitement a couple of weeks ago in the press around the world. What's next for you? What are you going to be focusing on in 2022? What themes continue to get you excited in this area? Take the floor and talk a little bit about what's happening.
Well, I've always thought, and I've written about this, that the kidney would be the first model, the first organ to get into the clinic.
Yep.
And the major reason for that is that if you put a kidney in, and if for some reason it doesn't work as well as you hoped, or it gets rejected, or if you develop an infection that you're finding difficult to treat because the patient's immunosuppressed, which makes it more difficult to treat infections, you can take the kidney out, stop all the immunosuppressive therapy, and put the patient back on dialysis that it was on before. And if you do that in a timely fashion, hopefully the patient will not be, it won't be detrimental to the patient. We would have had a pig organ maybe for 6 months or maybe a year, we don't know, and then you have to go back on dialysis. But that is a backup plan for the patient. So the patient is not committing himself just to this transplant, it's either this or death.
Mm-hmm.
With the heart, it's more difficult to justify that. If the patient is not suitable for an assist device, a mechanical device, can't get an allo transplant, you could say, let's put in the pig organ. But if the pig organ fails, he's still not suitable for an assist device, and maybe you still can't get an allo transplant. So with the heart transplant, it's much more of a patient, a hit or miss thing. Is it going to work? In which it'll save my life. If it's not going to work, I'm going to die. With the kidney, it's that you have this backup plan that you can revert to dialysis. So I think what will happen now is that probably the Maryland group will probably be asked to see some patients around the country for whom there does not appear to be any other option. They're not suitable for an assist device, they can't get an allograft or something else, and they will be asked, can you do a heart transplant in this patient? And the the Maryland group will have to go to the FDA and say, can we do another one on compassionate grounds, which is what they did the first one. If the FDA has approved the first one, I don't see any reason why they shouldn't approve a second one or a third one, as long as this first patient does reasonably well. If he doesn't do well, then of course they'll draw back. But I still think the kidney is the best approach, and I think we're at a stage now that we could set up a small clinical trial to prove the point that these pig kidneys are going to work, and we've solved most of the major problems. The problem at the minute is that the baboons and monkeys have antibodies against the pigs that are best for humans. And many humans do not have antibodies against those. So we've got a situation where we have a pig that we think will be excellent in a patient, but it's difficult to prove that in a baboon because the baboon has got antibodies against it. It's like saying we have a drug that we think is going to work well in a patient because all our lab tests doesn't work very well in baboons. Oh, but now we're going to try in a baboon to show that it's going to work in the human, which is a ridiculous situation. So I think we've got to the point where we should bite the bullet and use the best pig we've got, the best immunosuppressive therapy we've got, and perhaps study 4 patients. For example, you transplant one, you wait 3 months. If the patient's doing well, no infections, no problems, the kidney is working well, not being rejected, then you do the second patient. And over the course of a year, you do 4, by which time the first one is being followed up for a year by this time. And then you get an idea, is this working or isn't it working? Have we seen complications we didn't expect? And if it's working and you don't see these complications, you then increase the numbers and do a much bigger trial. I think for those 4 patients, it might be life-saving, or at least it will bridge them till they get a human organ. And we would learn an immense amount from that, much more than we're learning at the moment from the monkey models, which I say are not really relevant anymore to the patients. So I think that's how we'll expand over the next few years. A good clinical trial in the kidney and perhaps some one-off cases of the heart until we've got enough information to know we could now do a bigger clinical trial.
It's fascinating work, Dr. Cooper. And as I said, you know, I followed you for a few decades now, got your book over here, and it's just been amazing watching you bring this to fruition and translation in this way, and really going to be rooting you on as you continue this amazing work. For everybody that is going to be listening to this episode across the podcast networks or watching on the YouTube channel, you've been listening to Dr. David Cooper, a pioneering heart transplant surgeon and xenotransplantation researcher, doing really amazing things, talking to us today at Massachusetts General Hospital, Harvard Medical School. Dr. Cooper, I want to thank you for taking the time out of your Sunday to come talk to us. Obviously, thank you for everything you have been doing the last few decades. And as we say on this show, thanks for helping to create a better tomorrow through what you've been doing. It's really an amazing story.
Thank you very much indeed.